Logo, Microsoft Teams. Text, ODS Seminar Series, Using N-of-1 Trials to Personalize Diet Interventions. March 5, 2025, 16:01 UTC. Recorded automatically. Office of Dietary Supplements Seminar Series. Any opinions expressed by ODS seminar speakers or attendees do not necessarily reflect the views of the National Institutes of Health, the Department of Health and Human Services, or the United States Government. ods.od.nih.gov. NIH National Institutes of Health, Office of Dietary Supplements. Barbara Sorkin, NIH/O.D, speaks to us from the side of the slide presentation.
Welcome, everybody. Are we on, James?
Yep, we're good.
Okay, thank you. Welcome, everybody, to today's NIH Office of Dietary Supplements seminar. Here is our caveat. I am Barbara Sorkin. Not what I wanted to do. Let me full screen this again. And I, in addition to coordinating the Office of Dietary Supplements webinar series, and we apologize for any glitches, we are using the Microsoft Teams platform for this series for the first time today. In addition to coordinating the Office of Dietary Supplements seminar series, I co-direct the NIH's Consortium Advancing Research on Botanicals and Other Natural Products, our carbon program. Before I introduce today's seminar speaker, coming attractions, and then some logistics. Our next ODS webinar will be on Wednesday, April 23rd at 11 a.m. US Eastern Time, and will be given by Dr. Amala Somyanath, the principal investigator of the Carbon Center at Oregon Health and Science University, that's titled Botanicals Enhancing Neurological and Functional Resilience in Aging. Dr. Somyanath's webinar title is Bringing Botanicals to Clinical Trial, Groundwork and Challenges. If you'd like to join that webinar and you're not already on our seminar's mailing list but would like to be, please see the chat. I'll get the email that you should email your email address to be added to our mailing list into that as soon as I finish introducing today's speaker. And as long as I'm mentioning the chat, please do use the chat if you have any questions for Dr. Schmid today, or if you have any problems with the audio visual for the webinar, and we will try to help you from the NIH end. And with that, it is my pleasure. And some notes about webinar behavior, and there we go. There's the forward button, found it.
ODS event guidelines. https://ods.od.nih.gov/about/ods_event_guidelines.asp. Attendees are expected to uphold the professional and educational purposes of meetings by respecting the rights, views, privacy, safety, and dignity of all people in their speech, postings, and other actions. Keep all comments relevant to the event topic. Refrain from engaging in harassing speech or other inappropriate behavior, posting insulting, obscene, discriminatory, or threatening comments, disrupting the conversation, including with spam or repetitive posts, use of AL-based or AL-assisted note-takers. If you see or experience a violation of these guidelines, please contact ODS at ods@nih.gov or send a private message to the meeting host. Participants who engage in any of these behaviors will be given a warning from event organizers, asked to stop the behavior and be expected to stop immediately. Participants who continue to display inappropriate behavior after being given such a warning will be removed from the event.
So certainly in your questions, please be respectful of the other attendees. And with that, I am pleased to introduce today's speaker, Dr. Chris Schmid. Dr. Schmid is a professor and past chair of biostatistics at the Brown University School of Public Health, where he co-founded the Center for Evidence Synthesis in Health. He directs the Biostatistics, Epidemiology, and Research Design Core of the Advanced Rhode Island Center for Translational Science. Dr. Schmid received his Ph.D. in statistics from Harvard University. He's a fellow of the American Statistical Association and of the Society for Research Synthesis Methodology. Chris serves the field of biostatistics and clinical research in many ways, including as a journal statistical editor, and he's a former member of the Drug Safety and Risk Management Committee for the Food and Drug Administration. He's published more than 300 articles and has served on numerous data and safety monitoring boards, study sections, and advisory panels. Of interest to us at NIH, his research also of interest to us at NIH. His research has included methods for developing and accessing predictive models using data from multiple different sources. But for today's seminar, I've asked him to focus on the design and analysis of data from N-of-1 clinical trials. I know this is an area of great current interest in both nutrition research and dietary supplement research. And now, because we have had trouble with sharing, all right, with allowing our speaker to share, I am going to bring up his presentation and let Chris take the microphone. So here is his presentation. And Chris, take it away.
N-of-1 trials to personalized diet interventions. Christopher H. Schmid, Brown University School of Public Health, Department of Biostatistics, NIH Office of Dietary Supplements Seminar, March 5, 2025. Email, christopher.schmid@brown.edu.
Okay, thanks, Barbara. Welcome, everyone. So Barbara asked me to talk about N-of-1 trials, and so this presentation is really a very basic introduction to what an N-of-1 trial is, and I'm going to try to put it into some context, both for dietary interventions, and I'm going to talk about a study that I was involved with where we used N-of-1 trials to do a dietary intervention, but also talk about it in the context of other healthcare and also of other experimental designs that you may be more familiar with. So next slide.
Collaborators. Graduate students, Zhou Servadio, Yudin Wang, Jiabei Yang, Kashin Chu, Fan-Dai Chang, Joanna Walsh. Research teams, Tufts Medical Center, Deborah Zucker, Robin Rutherser, UC Davis, Rich Kravitz, UCSF, Ida Sim, Greg Marcus, U Cincinnati Medical Center, Heather Kaplan, Christy Schuler, National Children's Hospital, Lisa Opapari Oregon, Columbia University, Nawadwan. So I just want to mention some of the many collaborators I've had over the years, and I'm going to talk about some of these studies, but various graduate students that I've worked with and various research teams, both at my former life at Tufts Medical Center and while I've been at Brown, and it's been a pleasure to work with all these people. Next slide. And this research has been supported by various grants from the NIH and from other institutions. Next slide. Outline, personalized studies, N-of-1 trial designs, examples, mobile interfaces, combining N-of-1 trials, analysis, enhancements. So what I want to talk about today is sort of introduce you to this idea of personalized studies, of which N-of-1 trials is one type. Talk a little bit about what an N-of-1 trial design is and how it differs from other designs, give you some examples of the work, and talk a little bit about some of the projects I've worked on, and in particular talk about things like how you would implement one of these studies. And in many of the studies I've been involved with, we've used mobile apps, particularly phones, to help people participate in the study, since they're doing this on a personal basis. Talk a little bit about the idea of, I do a lot of work in meta-analysis and talking about how we could combine individual trials together to get more information about groups of individuals. I will try to say a little bit about the analysis of the data and the presentation of the data, although I'm going to try to keep the statistics to a minimum here, and then talk a little bit about the end about some enhancements that we've been sort of working on to make this research more generalizable. So next slide. Personalized healthcare. Individualized molecular/genetic/omic therapies. Mobile apps, study you/study me/self-e. Small, personalized, data. Predictive models using electronic health records. Patient-provider networks like Healthy Heart, Improve Care Now. Patient data repositories like Folia Health, Patients Like Me. Zener, 2022, Study Me, a new mobile app for user-centric N-of-1 trials. Trials 23, 1045. Konigorsky et al., 2022, StudyU, a platform for designing and conducting innovative digital N-of-1 trials. Journal of Medical Internet Research 24:E35884. Dasklove et al., 2021, Selfie, Smartphone-Supported Guidance for Customizable Self-Experimentation. Chi 21. Duan et al., 2022, Personalized Data Science and Personalized, N-of-1, Trials, Promising Paradigms for Individualized Healthcare. Harvard Data Science Review Special Issue 3.
So personalized healthcare has a lot of meanings to people. And so I'm going to talk a little bit about various aspects of that at the beginning. So, one is this idea of individualized therapies that might be molecular or genetic or genomic or proteomic or whatever, particularly in areas like cancer where we're trying to target a treatment right to an individual. And so those are often called N-of-1 because in some sense they are personalized treatments. But those are going to be a little bit different from the types of studies I'm going to talk about today. Oftentimes, these studies, as I mentioned, have mobile apps connected to them. And in particular, I've worked with a couple here. One of my colleagues, Stefan Kornogorski in Germany, has developed something called Study You, which is an app that allows a clinician to work with a patient together. Study Me, which would allow an individual to do their own study. For example, if you were interested in training yourself, what if I eat this food before I go to bed? Do I sleep better? That sort of thing. And Selfie, which is another self-experimentation tool that's been developed at Brown by one of my colleagues, Jeff Wong. A third aspect here is the idea that we have, everybody's familiar with big data, but in this case, we're talking about small data because the data really are focused on individual. Although you might have a lot of information about yourself, the inferences are really going to be made to you. And so that's one way that the N-of-1 trial really differs from bigger trials where we're more interested in sort of the average effect. Another aspect of personalized healthcare that sometimes people use is using electronic health records to try to develop predictive models to say, well, if a person has certain characteristics, what's their likelihood, for example, of having cancer or having a heart attack or so forth. And you'll see a lot of these tools, many of them developed at the NIH online that people can use for themselves. Another aspect is the idea of patient-provider networks. And so I've worked on a couple of projects with these groups. Improved Care Now is a group of parents whose children have inflammatory bowel disease, and that's one of the trials I'm going to talk about, where we worked with these networks to recruit and to design the study in connection with those groups. Another one is Healthy Heart, where we did a study with people with atrial fibrillation who belong to a nationwide network, and we were able to involve those individuals in that study. And then finally, there are patient data repositories, Patients Like Me. I work with a group called Folia Health, where people can put their own data into a database, share it with others, and try to find treatments that might work for them. So these are all personalized healthcare initiatives, and I'm going to focus on some of them. Some of these will be involved in N-of-1 trials, but it sort of is a nice way to think about as an overview for you of what personalized healthcare is. Okay, next slide, Barbara.
Recommendations for personalized nutrition. Dietary guidelines for Americans represent population-level recommendations. Some at-risk subgroups are addressed, for example, hypertension. Not intended to provide ideal nutrition guidance for individuals. But recently, personalized approaches have been advocated and shown to work. We'll give example of diet study for inflammatory bowel disease in children. Adams et al., 2020. Guiding Principles for the Identification and Implementation of Personalized Nutrition Approaches that Benefit Health and Function. Advances in Nutrition 11, 25-34, 2020.
So for personalized nutrition, I participated in a panel that wrote a paper back in 2020, came out Guiding Principles for Personalized Nutrition Approaches. And looking back over that paper now, we talked about N-of-1 a little bit in there. I gave you the reference in case you want to look it up. Most of the dietary guidelines for Americans that are put out represent population level recommendations. And there are some at-risk subgroups that are addressed. For example, individuals with hypertension who may, or individuals with diabetes, for example, and how they might better treat their condition with dietary interventions. But in general, these guidelines are not intended to provide nutrition guidance for individuals. But recently, personalized approaches have been advocated and shown to work, and I'll show you an example of that in one of our studies where we looked at a dietary intervention for inflammatory bowel disease in children. Next slide.
Examples of PN information and tools. A table with 2 columns, one titled Widely Accessible Tools, which includes descriptions for the headings, demographic information, phenotype-based information, and lifestyle-based information. The second column is titled Less Accessible Tools, Special Populations, Motivated Consumers, and it includes genomics-based information and tools and lifestyle-based information and tools. Adams et al., 2020, Guiding Principles for the Identification and Implementation of Personalized Nutrition Approaches that Benefit Health and Function. Advances in Nutrition 11, 25-34, 2020.
So this is a figure from our paper. It's a little bit blurry, but basically showing you many different tools that can be used for getting personalized nutrition information, for developing models and techniques to improve your education. And so again, this is sort of in a much broader context, many ideas related to omics or related to electronic health records or related to some of the information that we collect through smartphones and so forth. Next slide.
Text, 2 types of personalized, N-of-1, trials. Type 1, single patient crossover trials, typically conducted in patients with chronic conditions, individual patients given candidate treatments in double-blinded, random sequence of alternating periods, determine most effective treatment for that patient. Type 2, experimental design specific to one patient with rare disease to facilitate personalized medicine, treatment personalized to patient, outcomes may not be repeatable, for example, improve or not. Typical example, cancer treatment tailored to specific tumor. Selker et al., 2022, a useful and sustainable role for N-of-1 trials in the healthcare ecosystem, Clinical Pharmacology and Therapeutics 112-224-32.
So there basically are 2 types of personalized trials, and we talked about this in a paper that I was a co-author on by Selker et al. That came out a couple of years ago. Type 1 is the type that I've generally worked with, and I'm going to talk mostly about today. These are single patient crossover trials in people with chronic conditions. People are given candidate treatments in some sort of randomized double-blind fashion, where they get the intervention during some periods and they get the control in some other periods, and compare the results in those 2 periods to see whether the treatment worked for them. The second type of N-of-1 trial is really related to those designs where you are tailoring a treatment to one patient. For example, as I mentioned earlier, for cancer with a rare with a rare disease, where you want to facilitate personalized medicine because there's not some sort of general intervention that could be applied to everybody. And so this is not the kind of study that I'm going to talk about today, although it does sometimes go under the framework of N-of-1. And basically the outcomes here may not be repeatable because people may either improve or not improve. And so you can't really test them in a crossover fashion because they're not returning to their baseline state throughout the study. Next slide.
Personalized nutritional interventions for IBD. Use information on individual age, insulin sensitivity, or gut microbiome to develop targeted nutritional advice. More personal approach might improve motivation and adherence. Precision nutrition, individual dietary advice based on quantitative understanding relationship between individual, phenotypic response to diet and food consumption. Levels of personalization, general nutritional advice, individual nutritional status and omics information. Focus on treatment that is personalized to biology and behavior. Outcomes included malnourishment, inflammation, biomarkers, symptoms. Willens et al., 2023. Personalized dietary regimens for inflammatory bowel disease, current knowledge and future perspectives, pharmacogenomics and personalized medicine. 1615-27.
So for what are different personalized nutritions that could be used for inflammatory bowel disease? We could use information on an individual's age or their insulin sensitivity or their microbiome to develop targeted advice. And there's a nice paper on this by Wellens et al. That talks about personalized approaches that might, for example, help people improve their motivation and adherence to some of these initiatives. And so that might be one reason why you want to personalize the trial and personalize the approach that's being taken. Also, you might want to look at sort of a precision nutrition approach where you're looking at individual advice based on some sort of quantitative understanding of the way the individual is relating to their diet, their food consumption, their phenotypic response, and for example, related to their own microbiome. And so there's various levels of personalization that you can use here. You could use general nutritional advice that's tailored somewhat to the individual, or you could use the individual's own personal situation to tailor that advice directly to them, or you could use their omics information, and this will become increasingly possible as we get better and better at doing this. So you might say, for example, your gut has certain microbes in it, and we think this is the diet that's best for you. So the idea here is you're focusing on treatment that's personalized to the individual's biology, but also to their behavior. What's the best diet that they can actually stick to and it can actually make them feel better? And so the outcomes here would include a variety of things, including malnourishment, inflammation, biomarkers, and symptoms. All right, next slide.
Single-case experimental designs. Personalized protocol for each participant, compares baseline stage to intervention stages, repeated measurements taken in each stage to estimate average effect, variance, and trend. Many types, withdrawal/reversal, multiple crossover, multiple baseline, stepped wedge, alternating treatment, changing criterion, N-of-1, randomized multiple crossover. Can measure individual treatment efficacy. Can combine single-case and multi-level structure, estimate average effects, assess heterogeneity, improve individual estimates. Nichols et al. 2015. The Essential Guide to N-of-1 Trials in Health.
So single-case experimental designs have a long history in science. They've been particularly used in social sciences in the areas of education and psychology, where the idea is that each participant has their own protocol. And the basic idea is you're going to measure them in a baseline stage, and then you're going to introduce an intervention and see whether they change. And the idea is that repeated measurements are taken in each stage, and you estimate an average effect and some kind of variability and potentially trend. And you look back and see how they did on those periods and make a decision as to whether that treatment is working for them. Now, there are many types of single-case experimental designs, and if I had more time, I would go into these. But the one I'm going to be basically focusing on is the first one, which is often called a withdrawal or reversal design, where there's a multiple crossover setup. People can cross over back and forth between the control and the treatment. You can measure them multiple times and see how they did on those. Some other designs that have been used are the multiple baseline design, which is sort of a form of stepped wedge, where people only cross over once. They start in the baseline and they cross over, but the way you determine whether that crossover really introduced an intervention effect or it was just a time effect is that you cross different people over at different times, and then you see whether there's a consistent effect when they cross over rather than the effect being at a particular time. And so obviously that's related to the stepped wedge design, which is very common with cluster randomized trials. Other types of single case designs are alternating treatment, where you alternate back and forth between treatment and control. The changing criterion design, where you're looking at basically differences across time in the way people actually implement their intervention. And then the N-of-1, which is really a randomized multiple crossover trial, which is what I'm going to focus on today. So the point of all of these designs is that they can measure treatment efficacy at the individual level rather than at the population level. And one of the innovations that we introduced, a few years ago was to combine these single case trials into a multi-level structure so that you can not only estimate the individual effects, but you can also estimate average effects and assess heterogeneity. And the book by Nichols et al. Is sort of a nice introduction to kind of all of these issues. Next slide.
N-of-1 design. A row of orange and blue boxes, each with either A or B inside and a row of red dots across the top. The first box is orange with an A and 6 dots, the second is blue with a B and 6 dots. The third is an orange A with 6 dots, the fourth a blue B with 5 dots, and the sixth is an orange A with 4 dots. Text: single patient multiple period blocked crossover trials to estimate individual treatment effects. Randomized multiple phase withdrawal/reversal design. Multiple measurements per period. Potential missing data. Compare measurements in A periods with those in B periods. May need washout to control for carryover. Kravitz and N-of-1, 2014. Design and Implementation of N-of-1 Trials, A User's Guide, AHRQ publication.
So the N-of-1 design, I have a little picture here. And so the way you can think about this is think about you have two interventions or two treatments, A and B, and you're continually alternating between them. The solid black lines here indicate 2-period blocks where you randomly assign the person to either A or B in the first period or the second period. So in the first period here, the first block they got A and then B, and the second block they got B and then A. And the red dots indicate measurements that you might be taking on the individual during those periods. And notice that you don't have the same number of red dots in each period because people may not always respond every day for some reason or another. So these are single patient, multiple period blocked crossover trials that estimate individual treatment effects. And the idea here is that you're going to compare the measurements you took in the A periods to those you took in the B periods, but you need to account for some of the sort of time series aspects of what's going on here, which is that, there's a time trend potentially involved, there's potential carryover, and other issues such as correlation that you have to account for that I'll talk a little bit about going forward. So next slide.
Motivation for personalized, N-of-1, trials. Implement research in community. Outside of specialized populations in traditional trial settings which may not apply to local practice. Expand experimental research into underrepresented populations and everyday life. Facilitate individual decision-making. Estimate individual treatment effects. Assess heterogeneity of treatment effects.
So what's the motivation for doing these trials? Well, when we first started out in this, one of my colleagues, Deborah Zucker, thought that, one way that this thing could really help people out is that many trials are done now in very specialized settings like academic medical centers, where it's not really a representative sample of individuals who have that condition. So if we can personalize the trials and make them available to individual clinicians and individual people, then we could maybe expand research into the community outside of these specialized populations. And we could also expand the experimental research into populations that are underrepresented in current trials. So people who don't necessarily live near an academic medical center, people in rural areas, people who may not have access to some of these treatments, and also expand it into everyday life. If you can think about it, you could do one of these studies for yourself. And for example, I might want to know whether, if I ate blueberries every day, do I feel more energetic? Well, I could actually run that little study in myself if I wanted to, and I could randomize myself back and forth between eating blueberries or not eating blueberries. So this can facilitate individual decision-making. It can help you estimate whether a treatment works for you, but it can also assess whether the treatment is varying for you. In other words, does it sometimes work and sometimes doesn't work? But if we run it in multiple people and we look at results across people, we can see whether these treatment effects are heterogeneous. Because one of the difficulties with standard clinical trials is that we really are only getting an average effect. And unless we can sometimes look at subgroups, but we really don't know whether a treatment works for everyone. And if a study comes out and says that a treatment works, the assumption is often made that it works for everybody, and so we're going to give everybody that treatment, and that may actually not be the right thing to do. Next slide.
Heterogeneity of treatment effects. Center-based RCTs give average effects, but average effects may not, and in some cases demonstrably do not, apply to the individual patient. A graph with a standard bell curve titled Panel A. It has net treatment benefits on the x-axis from negative 1.5 to 2.5 SD units, and proportion of subjects on the y-axis. The curve is divided down the middle with a line at 0.5 SD units that is labeled, true mean effect in population. The right half of the curve is labeled individuals deriving greater than average net benefit. The left half of the curve has a gray column between negative 0.25 and positive 0.25. It is labeled, zone of no clinical meaningful effect. The area between the center line of the curve and the gray column is labeled individuals deriving less than average net benefit.
So here's the basic idea is that, the center-based randomized controlled trials that we're all familiar with allow you to estimate average effects, but average effects may not apply to the individual person. And so if we look at this graph here, this is basically a simple normal curve, and maybe on average there's a benefit of half a standard deviation unit to everybody, but you can see that there's a group of people who don't get benefit, and that gray region is a region of sort of clinical indifference. So some people are getting very little benefit at all. Other people are getting a lot of benefit, and then there's a few people who are actually getting a negative benefit. They're getting a harm from this treatment. And we'd like to be able to identify those individuals, so that they don't have adverse effects and the treatment doesn't actually hurt them. Next slide.
Text, N-of-1 trials, personalized protocols. Design own study, select own, multiple, outcomes, select own treatments, determine data collection process, need simple interface preferably on mobile platform.
So one of the other advantages of N-of-1 trials is, in addition to allowing you to figure out whether something works for you, it also allows you to design your own study. You can select which outcomes you're interested in. You can select which treatments you'd like to look at. You can determine how you want to collect your data. For example, do you want to collect data every day, every week, twice a day, and so forth. And generally, if you have some kind of simple interface on a mobile platform, you might be able to do this trial pretty much yourself. You can enter your own data, you can design your own study, and that's what we're kind of trying to work toward. Next slide.
Indications for type 1 N-of-1 trials. Substantial therapeutic uncertainty about treatment, heterogeneous treatment effects, stable chronic condition, short-acting treatments with rapid ramp-up, negligible persistence of treatment effect, no carryover, outcome expected to return to baseline after each period, measurable easily collected outcomes.
So what are some of the indications? N-of-1 trials don't work for every possible situation. So first of all, you want to have substantial uncertainty about the treatment effect. If you know if the treatment works for you, obviously you don't need to do a trial about it. Ideally, also, the treatment effects are heterogeneous, because if they're not, then in a simple randomized trial, it should be able to tell you whether it works for everybody or not. It needs to be a stable chronic condition generally, because we do have this multiple crossover aspect. And so if we really want to be able to compare people across time, we need to have them at the same sort of baseline setting in each period so that we can make common comparisons. We need to have treatments that act very quickly and don't last a long time, because if there's a long either ramp up to get the treatment working, or the treatment has a long half-life, then these trials are going to have to be really, really long for us to cross back over. We also don't want to have any carryover, so we don't want to have the effect of one treatment carrying over into the next period when the next treatment's given, because then it's going to be hard to distinguish which is the treatment effect that's really working. So we want the outcome to return to baseline after every period so that we can do the crossovers. And then finally, we want measurable, easily collected outcomes so that people can do this easily for themselves. Next slide.
Key design elements for type 1 N-of-1 trials: assigning treatments, allocation concealment, blinding, replication, carryover, multiple outcomes, sample size.
So some of the key design elements that I want to just briefly go over is, how do you assign treatments here? How do you conceal what treatment has been assigned? How do you do blinding? How much replication do you need? What does it mean in N-of-1 trial, since we have one person? What is carryover? How might we deal with multiple outcomes? And then what are some of the issues related to sample size? So next slide.
Assigning treatments. Randomization within crossovers, systematic counterbalance design AB/BA, alternating treatments, blocking overtime to control temporal effects.
So when we assign treatments, we usually like to randomize. And so if you think back to that picture I showed you, we're randomly allocating people to periods. It might be a week-long period, it might be a month-long period, it might be a day-long period, but you're randomly being assigned to the treatments. Another possible way of assigning the treatments, if you can't or don't want to randomize, is you can systematically counterbalance them. So for example, in a 4-period trial, you might decide to do AB followed by BA. The reason for that is if you did a complete randomization, you might get AB, AB, and then obviously B is always following A, in which case you can't really distinguish the effect of the intervention change from a time change. Another way you could do it is by alternating treatments, although obviously that has some drawbacks as well. And then typically we would block over time. And what I mean by that is that we would want to make sure that every 2 periods, for example, we randomize people to either A or B. That has a couple of advantages, but the main one is that you don't know how long people are going to continue in the trial. And if you have a design where they've had a lot of one intervention at the beginning before they get very many of the other and they drop out, then you're not going to have a good comparison between the two because you won't have enough A's and B's. So we want to make sure that they remain fairly equally distributed over time. Okay, next slide.
Blinding. Patients very involved with study may try to guess treatment, especially as receiving both subjective outcomes influenced, without pure blinding. Preferences of individual patients may generalize to themselves in future, but not to others as in parallel trial. For example, treatment preferred for convenience. Blinding may preclude accounting for some of specific and non-specific treatment effects. Patient may prefer red pill to blue pill, and for this patient pill color may become part of treatment. Allocation concealment.
So blinding is something that we always try to do in studies, and it's particularly important here because the patients are very involved with their study, and they may or will try to guess what treatment they're on. And so this could affect any outcomes that are subjective outcomes, like patient-reported outcomes that they're reporting and that they're interested in. But one thing that's a little bit different with an individualized trial compared to a group randomized trial is that the preferences of individual people here may generalize to themselves in the future, but not to others. And let me give you an example of that one of my colleagues mentioned, N-of-1, many years ago. Let's say that you blinded people to a pill that they were taking, and the blinding was such that one of the pills was red and one of the pills was blue, so that you could keep track of which was which. So normally this wouldn't be much of a difference because everything else about the pill is the same except for its color, and one wouldn't expect the color to have an effect. But let's say you had an individual who's doing an N-of-1 study and they really like the color red, then they might prefer to take the red pill. And so there might be some subjective thing going on there that you wouldn't have in a normal trial. So the thing that's important with the blinding is that you have to make sure that it may represent not just the effects of the pill, but also the person's subjective thoughts about that pill or whatever treatment they're offering. And then finally, the allocation concealment is also important. You don't want people to know kind of what they're doing, although obviously in some cases, this is going to be really difficult to do. For example, if you're comparing meditation to yoga, most people are going to know which one they're doing. And so you may have to blind others to it. Maybe their provider, their clinician, or maybe the analyst is blinded. Okay, next slide.
Replication. Need sufficient number of crossovers and measurements within period to have enough information about within and between period variability. Optimal allocation depends on expected size of variance components, measure validity on different time scales, likelihood of dropout, tendency to become less careful about measurement and following protocol over time.
So replication here, we don't have multiple people in an N-of-1 trial, so where's the replication coming from? Well, the replication is basically coming from the number of measurements that you're taking on each person. So you need a sufficient number of crossovers and measurements within each period to have enough information to be able to do the statistical analysis. And how do you optimally allocate these? Well, this is going to depend on things like how much within the variability is varying across the individuals or within the individuals, how likely they are to drop out, or how likely they are to become less careful about measurement over time and following their protocol, so that later measurements may not have the same impact as earlier measurements. So all these things can sort of affect how you replicate the design. Okay, next slide.
Carryover. Carryover always threatens validity in crossover trials. Bias toward null if carryover present and not controlled for. Hard to know if it exists. Tests for it are not very powerful.
Carryover is another thing that is very much a problem in crossover studies. And there's usually a bias toward the null effect if the carryover is present, because the idea is that if you're comparing a treatment with a control, but there's carryover of the treatment into the control period, then the control period is going to look more like the treatment period, and so the two will sort of meld together, and you won't have as big an effect as you'd like. But it's really hard to know if this exists unless you have some external information about how long the effect is going on, and tests for it are not very powerful. So, for example, you might be able to determine how long a drug lasts based on its half-life. You may not be able to figure out how long the effect of doing yoga lasts if somebody stops doing yoga. Next slide.
Carryover and washout. Can try to design away carryover away by washout. Deviates from pragmatic design principle. Might not be appealing to users, especially with active control. Washout increases study length and may compromise study completion. Removal from treatment may be ethical issue. May reduce patients' willingness to participate.
So you can try to design this away by what's called washout, which means is that you have a period in between the crossover when the person goes off each treatment and they're on nothing, so that by the time they start the next treatment, the previous one is washed out of their system. But this really deviates from a design principle that you want to make sure that people stay in your study, and if they're not getting any treatment, they may be more likely to drop out. And particularly if they're very sick, it may not be ethical to take them off a treatment. So that may not be possible to do. One of the issues with washout is it does increase the length of the study, and it may compromise whether or not people finish the study. So if it's going to cause people to be less willing to participate, that may not be the best design. And so we've come up with some other ways of approaching that. Next slide.
Analyzing carryover. Few crossover, so little information on carryover effect in single individual. Can take multiple measurements within each period, then deal with carryover analytically. Discard or downweight first measurements after each crossover. Apply biological considerations. Chris, easier to estimate with multiple individuals, meta-analysis.
So one way we can do this is by introducing what's called an analytic washout, which we've done in several studies, which means that, let's say it's a week-long intervention and we're going to measure it every day. We might just discard the first couple of measurements after you cross over and not analyze those, and sort of think of that as a washout period. You're still on a treatment, but we're not actually analyzing that period. So in effect, you're washed out. One of the problems when you're looking at individual studies is carryover is really only identifiable when you cross over. So if there's not many crossovers, there's not going to be much information on the carryover effect, which is why it's important to try to design it away. So there are also potentially biological considerations that you might be able to introduce here into your analysis. But in general, this is going to be easier to figure out if you have multiple individuals, because then you can look at carryover across individuals, and then you may have enough information about what the effect of the carryover is. Okay, next slide.
Multiple outcomes. Patients often interested in several outcomes. Standardization versus customization. Composite outcomes hard to interpret and may not be patient-centered. Could weight different outcomes. Might want to make probabilistic statements combining across outcomes.
Another issue that comes up is that people are often interested in multiple outcomes. They might be interested, for example, in how fatigued something makes them feel and how much pain they have. So there's one way you can handle this is by standardizing all the outcomes. That's sort of less patient-centered than customizing the outcomes. But by customizing them, then it may be harder to combine across individuals. So you have to there's a trade-off here that you have to consider. Composite outcomes are often hard to interpret and may not be very patient-centered. One approach that you could take here is that when you present the results to people on different outcomes, you could weight them differently. And you might even do that in an explicit manner by asking people what's the most important outcome to them and then making probabilistic statements about their results by combining across the outcomes. For example, if you have two outcomes and somebody tells you, well, this one's twice as important to me as the other one, then you'd give one of them twice as much weight in terms of determining their decision. Next slide.
Sample size. Individual trials. Purpose, treatment effect for one person, estimate length of trial, need number of crossovers and number of measurements per period. Sets of trials, meta-analysis, purpose, accurately estimate average effects in population and improve shrinkage estimates of individual effects, need length of each trial and number of trials, need information about both within individual and between individual variation and correlations among these. Prototype R-Shiny app developed. Yang J et al. Sample size calculations for N-of-1 trials. R. 14:2110.08970.
So sample size is a big issue. And in individual trials, the idea here, of course, being to estimate the treatment effect for one person, the sample size is really the length of the trial. And so that consists of the number of crossovers and the number of times you're measuring them per period. When you have sets of N-of-1 trials, so sort of a meta-analysis, the purpose here is to accurately estimate average effects in the population and potentially subgroups, but also to improve the individual estimates through the idea of shrinkage. And in this case, you not only need each trial, but you need the number of trials. So you're sort of balancing here information about within individual variability and between individual variability and the correlations among these. And one of my students, Jabe Yang, developed a nice shiny app. And I've given the reference here to the archive paper that we wrote. We're trying to turn this into a publication that sort of allows you to put in different types of variability to figure out sort of what's the optimal design for your study. Next slide.
My own N-of-1 studies. A table shows the points, crossovers, dx length, outcome, and comparison, for the conditions fibromyalgia, ADHD, chronic pain, IBD, atrial fibrillation, and daily mood. Text, fibromyalgia study had 2-week washout. IBD study alternating treatments and 2-week baseline. Atrial fibrillation study has 4-week follow-up after treatment and allows multiple N-of-1 trials of varied designs. Outcomes for last study are stress, focus, happiness, interventions are focused breathing, random act of kindness, 5 minutes physical activity, gratitude journaling. So
this is just a very brief overview of some of my own N-of-1 studies in a variety of different fields with different numbers of patients, different numbers of crossovers, outcomes, and so forth. And I don't really have time to go into these. I'm going to focus on the inflammatory bowel disease study, but you can see that there's a lot of different ways that you can apply these, and some of them have looked at specific treatment combinations. Others have looked at letting people choose their own treatment combination. So there's a lot of flexibility here in terms of what you're designing. Next slide.
N-of-1 interface. Purpose, simplify conduct and interpretation of trial results. Enrollment, randomization, prompts/reminders, data collection from participant, automated analysis in real-time environment based on mobile applications, feedback, perhaps with instructional videos.
So, I want to talk a little bit about the N-of-1 interface here. The idea here is to simplify the conduct and interpretation of the trial results. And so this can help out with enrollment, with randomization. It can actually do the randomization for you. It can provide the individuals with prompts and reminders about what treatments to take or when to record their outcomes, helps them collect their own data. It also you can automate the analyses so that you can feed back to them figures, tables, predictions, and so forth of how things are working. And you can also give them feedback in terms of what they should be looking at, how they should be interpreting their results. So these are all things we're sort of thinking about doing, and we've done in some circumstances, and not in others. Okay, next slide.
Statistical analysis. Structured time series with treatment factor. Descriptive analysis with graphics, visual inspection. Basic statistics comparing one treatment to another, for example, paired t-test. Modeling to address treatment effect, time trends, linear and nonlinear, time-varying treatment effects, autocorrelation, carryover, treatment, interactions, with time or covariates, lagged effects.
So statistically, I don't want to say a lot about this, but your data are basically a time series with a treatment factor. The typical way that N-of-1 trials are often done is just a descriptive analysis with graphics or some sort of basic statistical comparison like a paired t-test. But you can, if you have enough data, address with a fairly sophisticated model things like time trends, linear and nonlinear time trends, time varying treatment effects, correlations among the measurements over time, carryover, interactions, or even lagged effects. And so we've developed some models with this, and we've been trying to develop some software that will allow people to fit these models who may not actually want to do all the statistics themselves. Okay, next slide.
Rationale for using Bayesian models. Personalized nature of decision, desire to incorporate external, prior, information, patient, clinician, gives posterior distribution of how much better one treatment is than another, gives joint posterior distribution for composite statements about multiple outcomes, lack of sufficient data for frequentist to return significant result, can handle missing data as parameters, imputation, combining multiple N-of-1 studies gives average treatment effect and better individual treatment effects through borrowing of strength, Schmid and Yang. Bayesian models for N-of-1 trials. Harvard Data Science Review, 2022.
So we have typically used Bayesian models. So I don't really obviously have time to go into a huge discussion of Bayesian and non-Bayesian models, but a Bayesian model is basically one where you do the analysis combines the information coming from the data with external information that comes from what's called a prior distribution. And the reason we like this is because the prior allows you to put in beliefs about yourself that you might want to incorporate into your analysis. It also gives some advantages in terms of interpretation, because what it tells you is through something called a posterior distribution, which basically describes for any particular effect that you might be interested in, how likely that effect is. So for example, I could have done my study and I can, from the posterior distribution, tell you what's the probability that the treatment was effective, or what's the probability that the treatment was effective by a certain amount. And so if I have multiple outcomes, then I can look at a joint posterior distribution about composite statements saying, well, how well did you respond to this outcome and how well did you respond to this outcome? Standard kind of frequentist statistics oftentimes don't work in this sense because the usual concept of statistical significance is not necessarily reached because you don't have sufficient amounts of data. So for example, I might be able to tell you that there's an 83% chance that you did better on this treatment than on the other treatment, but that doesn't reach a level of 95% significance, but it still might provide important information back to the individual. Missing data is a common problem here because people don't always report all their outcomes. And so the Bayesian analysis also allows you to work with that fairly straightforwardly. So we wrote a little paper on this if you're into this kind of thing in the Harvard Data Science Review a couple of years ago. Next slide.
Combining N-of-1 studies, meta-analysis. Can treat each N-of-1 trial as a study and combine via meta-analysis, multi-level models. Get average estimate of treatment efficacy. Get improved estimates for individuals by borrowing strength. Compromise between population estimate, complete pooling, and individuals observed results, no pooling, weighted to observed if low variation or many crossovers, weighted to pooled, or subgroup, if little information for individual. Can include covariates for heterogeneity and subgroups. Can include terms for carryover, correlation. If treatments differ, can form network. Zucker et al., 1997, combining single-patient, N-of-1, trials to estimate population treatment effects and to evaluate individual patient responses to treatment. Journal of Clinical Epidemiology 50-401-410.
So the other issue is what do you do if several people have done an N-of-1 trial and you want to know, for example, well, how does this treatment work for helping your back pain, or how well does this treatment help my inflammatory bowel disease? And so you can treat each N-of-1 trial as a study and then combine them via meta-analysis using statistical methods like multi-level models. And this will give you an average estimate of the efficacy as well as better estimates for each individual by borrowing strength. And the idea here is that, let's say that the treatment worked somewhat well for you, but your probability of it being better is only about 75%. You're not really sure that it works for you, but it turns out that everybody like you, it worked well too, and it worked well enough that you're now convinced that, well, it probably worked for me as well, and had I had more information, I would have been able to definitively determine that. So that's kind of the idea of borrowing strength. And you can also include lots of other things in these meta-analyses. You can include covariates, looking at subgroups and heterogeneity. You can include terms for carryover and correlation. And if you want to look at multiple treatments, or if people have looked at multiple treatments, as they have in some of our studies, you can also do what's called a network meta-analysis to look at how these treatments compare to each other. So this was sort of the original paper that we wrote at the bottom with Debbie Zucker, sort of describes these ideas, but there's been a lot written since then as well. Next slide.
Text, produce study. A flowchart shows a timeline across the top from 0 to 34 weeks. On the left side of the flowchart is a large R for randomized. Two arrows point from the R to a row of boxes at the top and a row of boxes at the bottom. The top row boxes read, from left to right, usual diet, SCD, liberal SCD, SCD, and liberal SCD. The bottom row reads, usual diet, liberal SCD, SCD, liberal SCD, SCD. On the right side of the chart is a box that says, N-of-1 trial results review, final clinical assessment. An arrow points from the box to each of the top and bottom rows. Below the chart it says, data collection. Text, daily, stool frequency, stool consistency. Weekly, promise pain, promise GI symptoms, weight, patient-reported disease activity measures. Baseline plus each period, fecal calprotectin, diet adherence. Periodic, ICN registry, disease activity, clinician report, labs.
So here's the basic design of the diet trial I wanted to tell you about. We randomized people to either a strict diet or a liberal diet for their inflammatory bowel disease. They had 2 weeks at the beginning where they did their usual diet, and then they were randomized to either strict and liberal in an alternating fashion or liberal and strict in an alternating fashion. We measured a bunch of outcomes on them. And the reason we used the alternating treatment design here rather than the randomized, fully randomized, was that when we were working with the Improved Care Now network, the parents told us, well, they didn't think that some of their children would be able to do the strict diet necessarily for 16 weeks in a row, because these were 8-week treatment periods. So we ended up deciding to randomize the first period and then alternate after that. Next slide.
Produce study, design. Each child on usual, non-SCD, diet for 2-week run-in period for diet planning and baseline data collection. 4 treatment periods of 8 weeks each, 2 on each diet, assigned in blocks of 2. Patients randomized to either SCD or liberalized SCD in first period and then will alternate between these two conditions, ABAB or BABA designs. Ensures participants not on SCD diet for 2 consecutive periods in order to limit potential dropout. Comparative effectiveness of 2 diets compared to baseline diet for each child. Aggregate results across patients to estimate population-level effects.
So the design is basically they're on the usual diet for 2 weeks as a run-in, then they had 4 8-week treatment periods, 2 on each diet. And as I said, they were randomized in the first period and then they alternated. And then we compared the effectiveness of the 2 diets to each other and to the baseline period and we were able to aggregate results across the different patients in the study to look at population level effects. Next slide.
Analysis of produce diet trials. Use weekly pediatric IBD symptom scale, reported as a D-score, standardized mean of 50 and standard deviation of 10. Clinically important change is defined as a 3-point change in the scale in either direction. Clinically meaningful improvement defined as greater than 50% probability of clinically meaningful improvement of 3 points and a less than 10% probability of worsened outcome. Did not analyze first weekly measurement in any experimental diet period to eliminate carryover.
So we used various outcomes. One of them was the pediatric IBD symptom scale, which is reported as a T-score, standardized mean of 50 and a standard deviation of 10. And the clinically important change on this scale is a 3-point change in either direction. And so we defined clinically meaningful improvement as more than a 50% probability of a clinically meaningful improvement of 3 points and a less than 10% probability of worsened outcome, where these probabilities were determined through our Bayesian analysis. And to account for the carryover, we didn't analyze the first weekly measurement in any period because we felt that the week was enough of a time for sort of a washout of the previous diet effect. So these 8-week periods, we threw away the first measurement. Next slide.
Produce study, setup. 4 phone screenshots of an app. The first 2 show a vertical timeline of the produce study, baseline and usual diet now, diet a number 1 in 2 weeks, DB number 1 in 2 months, etc. The third screen shows a description of usual diet. Text, continuing eating your typical diet. By staying on your typical diet for 2 weeks, you will be able to compare how you feel when eating your typical diet to how you feel on the SCD or modified SCD. Now would be a great time to prepare for starting your first diet at the end of the 2-week baseline. The fourth screen shows a photo of various foods. Text, modified version. You can eat all the same food as on the SCD plus organic rice, oats, sweet potatoes, cocoa, and grade A maple syrup. Remember to follow the recommended amounts.
So here's the way it appeared on people's phones. They got a little diagram of the timeline of the study. And then they got some information about what the usual diet was, what the modified diet was, what the strict diet was. And they could sort of page through this at their leisure. Next slide.
Produce study, input data. A flow chart of phone screens from the app, showing the various screens to enter and select info to report stool consistency, stool frequency, and GI symptoms.
And this is sort of showing you how they would input their data. So for example, one of the outcomes was stool consistency. We gave them pictures of what their bowel movements would look like, and then they were supposed to enter what they looked like on that day, or their frequency and so forth. So they could enter their own information this way every day. Next slide.
Text, results of produce diet trials. Among 54 randomized participants, 21 completed the full 4-period sequence, 9 completed the study early after a single crossover, 2 periods, and 24 withdrew during the first or second period before completing both diets. 12 of 21 full completers, 5 of 9 early completers, and 4 of 24 withdrawals classified as responders on SCD compared to UD. 12 of 21 full completers, 4 of 9 early completers, and 1 of 24 withdrawals classified as responders on MSCD compared to UD. Most common reasons for withdrawal or early completion were occurrence of an adverse event, including worsening GI symptoms, N equals 11, lack of medical response, N equals 10, and not desiring to maintain diet, N equals 7.
So the basic results are among the randomized participants, we had 54 of them, 21 completed the full 4-period sequence, 9 completed the study early after a single crossover, so they dropped out basically after 2 periods at some point, and 24 did not make it through the first 2 periods. So 12 of the 21 full completers, 5 of the 9 early completers, and 4 of the 24 withdrawals were classified as responding to the strict diet compared to the usual diet, and similar numbers on the modified diet. So basically, if you went through the whole study, you were more than likely to say that the diet worked for you. But if you withdrew, it didn't very work for you. And there are a variety of reasons why people withdrew. Either their symptoms got worse, or they didn't have a response, or they couldn't stick with the diet. Next slide.
Produce GI symptoms, individual results. A collection of dot plots, with each plot having a whisker at the top and bottom. There are 3 columns, full completers, early completers, and withdrawals, and 3 plots for each group, SCD usual diet, MSCD usual diet, and SCD MSCD.
So here are the basic results of the trial. On the left hand is the full completers, in the middle is the early completers, on the right is the withdrawals. The top row of each is the comparison of the strict diet to the usual diet. Then we have the modified diet to the usual diet, and then we have the 2 diets compared. So if we look at the top row, the gray area is the area of clinical indifference, and you can see that a negative number here indicates a good response. So you can see that among the full completers, many of them had a response to the strict diet compared to the usual diet. And over on the very far right-hand part of that full completer, you can see a column labeled all. That's the meta-analysis. And you can see that the meta-analysis showed that there was, on average, a response to the full completers. But if you look at the withdrawals, you see a very different picture. You can see that very few of those people responded. If we go down to the very bottom, the comparison of the 2 diets, you can see that there's very little difference between the 2 diets. So the basic conclusion of the study was that the diet seemed to work for quite a few people, but that it didn't really matter which diet you were on. Okay, next slide.
Text, IBD system scale, SCD versus usual diet, full completers. A bar graph shows full completers from P1 to P21, with a bar at the end labeled all. Each bar is divided into sections, dark gray for probability first diet better than second diet, medium gray for probability first diet same as second diet, and light gray for probability first diet worse than second diet. The all bar is mostly dark gray with a small light gray section at the top.
And so another way of looking at this is just the probability of response. So this is looking at the full completers. So a dark bar indicates that you responded. The sort of lighter bar, the middle one there, says that we couldn't really tell. And then the very light one is the probability that you actually were harmed by it. So you can see that quite a few of the people who completed the study actually had a pretty high probability of getting a response. And some of them had a lower probability, but it looked at least like they weren't harmed by it. It just wasn't clear whether they had a really important difference. But if you look at the far right, under the all, there's a very high probability that everybody responded. So this is the posterior probability that's coming from our model. Next slide.
Text, IBD symptom scale, SCD versus usual diet, early completers. A bar graph titled Early Completers, showing participants P22 to P30 with an all bar, appears next to the first graph. The all bar is about 2/3 dark gray and 1/3 medium gray.
Then we sort of add in the early completers. You can see a similar picture, but not quite as much response. And then if we go to the next slide, we'll see the withdrawals.
Another bar graph is added titled Withdrawals, showing P31 to P50. The all bar is all medium gray.
You can see there that they had very much less response. And in fact, some of those people actually seemed to do worse on the diet than not. So, this was the story we told. And it was interesting because when we submitted the paper, a lot of the reviewers got hung up on the missing data and the statistical significance. But we felt the strong message here was these were 54 children who had tried lots and lots of different things. Nothing had worked for them. And we were able to show in about 40% of them that just trying a diet, changing your diet, would actually help your disease. So we thought that was a really strong response. Next slide.
Just jumping up to say that we're at 10 of the hour.
Yeah, I know. We're almost done.
Text, inflammation individual results. Fecal calprotectin. A dot plot titled Full Completer showing fecal calprotectin for each patient's baseline, first SCD, first MSCD, second SCD, and second MSCD.
So these are similar results. We also looked at some lab results looking at their calprotectin. This is sort of showing a similar thing, is that at the baseline, which is the plus sign, they had very high levels of this biomarker, but then as the study went on, those levels dropped. And so the next 2 slides, if you just want to flick through them quickly, Barbara, just show it for the other 2 groups.
2 more dot plots are added, for early completers and for withdrawals.
And again, the same message that most of the responses in the full completers. Okay, next slide.
Text. Produce study conclusions. Heterogeneity in response. SCD and MSCD were basically equivalent. Clinicians used results to make individual determinations of benefit. Most felt that full completers responded both clinically to symptoms and to biomarker. Early completers generally responded clinically but not to labs. Results for responders generally unclear. Most electing to continue dietary intervention chose to stay on less restrictive MSCD. N-of-1 trials are useful for determining not just whether dietary therapy with the SCD or MSCD works on average, but also for whom it works.
So basically, there's heterogeneity in response here. The two diets were basically equivalent. The clinicians used the results to make individual determinations of benefit. They found this to be very helpful for them. Most felt that the full completers responded both clinically to symptoms and to the biomarker. The early completers generally responded clinically, but not to the laboratory measurements. And the results for the I think that should be the withdrawals was generally unclear rather than the responders. Most elected to choose the dietary intervention that was the moderated one because that worked as well as the strict diet. So we thought that the N-of-1 trials here are useful in determining not just that the diet seemed to work on average, but also for whom it works. Next slide.
Ongoing work. Modeling categorical outcomes using GLMs. Simulating operating characteristics of model parameters. Sample size estimation to determine optimal allocation of effort among measurements, crossovers, and participants. Causal inference for compliance. Adaptive designs. R package for Bayesian modeling. Incorporation into general mobile app and user networks.
So ongoing work here is we're trying to do a lot of statistical stuff here. We're looking into making an R package. One of my students has been working on some causal inference updates for looking at compliance. And I'm working with a colleague to try to incorporate all of this stuff into a mobile app that could just be used in general, and to kind of put this into some user networks. So we're hoping to get some funding to do that. Next slide.
Implementation in healthcare systems. Need personal research infrastructure, need to fit into current healthcare ecosystem, requires generalizable and accepted processes, platforms, methods, and standards, sustainable value-based arrangements among key stakeholders, large organizations, government, health systems, hospitals, insurance, must support, must overcome initial cost and time barriers, new research paradigm. Selker et al. A useful and sustainable role for N-of-1 trials in the healthcare ecosystem, clinical pharmacology and therapeutics. 112 to 224 to 32 2022.
So, this can all be implemented in healthcare systems. This is laid out in the Selker paper. Basically, if we want to use individual trials here, we need to get key stakeholders to kind of buy into this. I have always thought that this would be great for HMOs and other healthcare organizations, just for individual clinicians to put in, to do trials on their individual patients and then to learn from each other. But there's obviously barriers we need to overcome there because it is a new research paradigm. Okay, next slide.
Conclusions. N-of-1 trials can be a useful tool to personalize treatments and trial designs and discover individual effects. They require some infrastructure, but tools are under development. Need to determine how best to return information to individual participants. Trials from different individuals can be combined to inform population effects and to improve predictions for individuals. Can be part of a larger network to inform treatment comparisons.
So basically, N-of-1 trials, I think, can be useful for personalizing treatments. They require some infrastructure, but we're developing the tools. We need to figure out how best to return information to individuals so that they can understand this. I think this is a great way of teaching people about science. We can combine information from different individuals, and we can put this as part of a larger network to inform treatment comparisons. Next slide.
References: Harvard Data Science Review Special Issue. https://hdsr.mitpress.mit.edu/special issue 3. A screenshot showing article links with images and descriptions.
There's a nice Harvard Data Science had a special review, special issue on N-of-1 trials that you can sort of download if you want. It's all free, and there are a bunch of papers on this, which if you're interested, you can look at those. And let me stop there.
Thank you.
And thank you very much for your time.
Thank you so much, Chris, for a great introduction to N-of-1 trials. I'm seeing applause on lots of the screens. And what I'm not seeing yet, okay, there is a question. Did the strict diet, the SCD, take into account, I assume also the MSCD, take school lunches into account?
That's a great question. And since these were parents who were very much involved, I don't know. I'd have to look back at the protocol, but I think that these were probably parents who prepared their own child's lunch during those periods. So obviously, you'd have to take the school lunch into account in a lot of cases. I mean, this is one of the issues that I think is very very crucial for implementing science. Is you could have a study like this that says this diet works great, but then it's not hard. It's not easy to implement this, right? Because people don't have control over what they're eating during the day. So that's, I think, something that we have to continually work on as researchers. And this is part of implementation science, right? Is how do you actually implement these interventions in a way that people will actually do them and can benefit from them? So that's a great question.
Okay, and everybody, please do get your questions into the chat.
I see one other question here about,
thanks.
Let's see, types of data that can be used for claims with regulatory authorities.
Yes.
Yeah, so I think this is sort of addressed in that paper by Selker that I mentioned. And this is where sort of the stakeholders have to be kind of brought together. You need to bring the researchers together with the clinicians and the patients, together with the insurers, together with the regulators. So, for example, if the NIH comes out with new dietary guidelines and they're based somewhat on personalized nutrition, then we have to make sure that, for example, if it requires that certain types of people have access to certain types of food, but that those foods are hard to get either because they're expensive or they're not really available, then we need to have some way of giving that food to people, right? So, there are a lot of programs we have in this country for feeding people, and we would have to build those kinds of things into that. So I don't know if hopefully that answers your question, but I think that's a really, implementation is a really important part of this.
Okay, and lots of great questions coming in. So if you had a multiple treatment traditional crossover trial with repeated measurements, could you not just analyze the results
Yes.
on an individual basis? And what's the difference between that and an N-of-1 trial?
So typically, crossover trials are usually 2-period trials. So you do each treatment once. And so you can get a comparison of the treatment within an individual, but because they've only done it once, you don't have any estimate of variability. Now, if during that period they've actually measured their outcome multiple times, yes, you do then have sort of an N-of-1 trial. So, for example, if I do one diet for a week and I do another diet for a week and I take a daily measurement, yes, then I've got 7 measurements on each, and that is sort of a form of an N-of-1 trial. N-of-1 usually, though, consists of multiple crossovers because the idea is you want to see whether these effects are varying over time as well. So, it could be that you did very well in 1 week, not because of the diet, but just because that particular week was different from the next week. So that would be one, sort of instance where the standard crossover trial may not be the same. But if you could definitely have a crossover with multiple crossovers, and you could think of that as an N-of-1 trial, yes.
How does that affect the sample size? So the next question is that for crossover trials that were not initially designed as an N-of-1, especially if there are multiple crossovers, can you retrospectively do an N-of-1 type analysis? Would that depend on your sample size? The number of crossovers or both?
Right, you certainly could do it. I mean, assuming that all the design principles that I talked about had been followed, like you really had crossovers that were randomized and so forth, and there weren't I mean, you could even look at time trends then. Yeah. So it's not a prospective N-of-1 trial, but like a lot of things, you can, you can sort of back into the design by adding it on. You could even, I would think, take a standard 2-period crossover and add on extra periods if you wanted to. If you were finding a lot of heterogeneity, you might want to adapt it. I didn't really say much about adaptive trials, but you can certainly embed N-of-1 trials into the adaptive scheme. And you could, for example, start off with 3 treatments and then drop one, or you could use some sort of Thompson-Sampson scheme to randomize people more frequently to the treatment that seems to be working, or whatever. So people are working on those kinds of problems. There's a couple of nice papers in the literature on that.
Is there literature on how to look for the kind of heterogeneity, and what level of heterogeneity would point you to the importance of looking at individual participants in a classical randomized trial? When should a larger study be broken down into the question as it's asked in the chat, N-of-1 studies?
It's hard to tell. I mean, I think so many large trials are not powered to look at subgroup effects, and so usually subgroup analyses are exploratory. But certainly, I think if you found a strong signal that there was heterogeneity either between subgroups or even within subgroups, that might prompt you to do some N-of-1 studies. So I don't know whether you could. I think you could use it as a way to indicate the need for N-of-1. I don't know if there's really a threshold. I think it would sort of depend on the problem and how much you thought that heterogeneity was important to the outcome you were looking at. Certainly, if some people were getting harmed and some people were getting benefit, then that's something that might prompt you to do an N-of-1 to figure out who those people are.
Or if you thought you might be able to predict response, maybe based on gut microbiota baseline differences.
Right. So I think particularly as you find factors in these data sets that you're collecting that seem very personalized, like the microbiome, that might prompt you to go to more personalized kinds of study designs. Whereas if you have treatment interactions that are, for example, if you found a treatment dose interaction, that's not something that's necessarily personalized. That's just saying everybody needs a different, or there could be, it could be, say, some people need a lower dose than others, right? But we do weight-based dosing anyhow, so there's some aspect to that. But you might find, for example, that that men reacted differently than women, in which case, if you thought that was a solid description of the data, you wouldn't necessarily need to personalize the trial. You just need to make different recommendations for men and women. But then if you found that certain women responded more than others, then you might want to delve a little bit more deeply. So one way is to kind of model this through regression, but another way is to actually study it at an individual level.
And then very, very quickly, because we are out of time, and I really appreciate yours so much, Chris. What about the incorporation of N-of-1 trials into oncology? And you talked about this a little bit, different cancers express different genes.
Right.
But also you talked about the fact that you sort of need a relatively standard baseline to do the multiple crossovers on top of.
So I could see, for example, one of the studies we did, the chronic pain study, you could do a pain study in people with cancer, and that's something where you could probably do a crossover, because if the pain's fairly constant, then you could look at that. The type of N-of-1 study I've just defined with multiple crossovers, you can't really do it with a condition that's resolving or that's changing markedly, because you just don't have a fair comparison. But you can certainly personalize the therapies, and so in that sense, an N-of-1 trial is very useful there, because you will be able to look at whether this treatment works for an individual. It's just a different type of analytic paradigm, right? It's whether it resolves the disease or doesn't resolve it.
Chris, many, many thanks. Lots of thanks in the chat. Really, really informative and helpful for those of us who are trying to understand this versus a classical randomized controlled trial. So
Well,
thank
thanks.
you so much for your time, for your patience with us learning the Teams platform along with you. I see some hands raised. I don't know whether I can in the Teams platform unmute you. So I think I need the questions in the chat.
Yeah, I can stay on for a little bit more if people want.
I can unmute the
Can
participant
you
that
unmute
has the hand
Johanna,
raised.
please,
Yeah,
James?
yeah, I got it. Johanna,
Johanna,
you can
do you?
unmute.
I put the question in the chat.
Oh, okay.
I was thinking about intractable seizure disorder and ketogenic diets because they're so difficult for patients. Have any studies been done on that or on using the N-of-1 model or with allergies? And particularly now that the guidelines for some of the food allergies are so changed from what they were 5 or 10 years ago. My concern is people going on these by themselves and you can't just do it on your own sort of without some guidance, it would seem, from what you've said. So I wondered if there were any data on trials of those sorts.
I don't know of any, but I mean, I haven't really followed that literature that closely. I totally agree with you that you want to make sure that people aren't doing this on their own. And so, I mean, this is always one of the risks when you put out software that people can use. As a statistician, I find this all the time that, people are doing analyses that are not very good, but they have the tools to do them. But I guess it's the same thing with, if you have a chainsaw, you better know how to use it or you could hurt yourself. So, but that's a great point. I do think there's a lot of other applications that you could use this for, but we have to make sure that the protocols are well done. And it may be that we want to come up with guidelines for these protocols and then have individual clinicians try them out with their patients.
Great.
Yeah.
Good idea.
All right. Good talking with you again, Joanna. It's been a while.
Thanks everybody for the questions and for joining us. And thanks so much for your patience with us, Chris, and for your time.
Okay.
For a great talk. Thanks.
Bye.
Bye.
Barbara and Chris both wave.